I'm excited to kick off our panel. I ask our panelists to go ahead and turn on video if you haven't already. To further inform us about best practices related to population-based total cost of care models, we've invited esteemed experts to represent several perspectives. PTAC members, you'll have an opportunity to ask our guests questions as well. The full biographies of our panelists can be found on the ASPE PTAC website. So I'll briefly introduce our guests and their current organizations. First, we have Lee McGrath, who is the Executive Vice President of Healthcare Services for Premera Blue Cross. Dr. Gary Puckrein joins us from the National Minority Quality Forum, where he is the President and Chief Medical Officer. We also have Dr. Robert Saunders. He is the Senior Research Director of Healthcare Transformation at the Duke Margolis Center for Health Policy. So welcome, and thank you for joining us. To start off, the Innovation Center at CMS has set the goal of having every Medicare fee-for-service beneficiary in a care relationship with accountability for quality and total cost of care by 2030. What do you see as the potential for accountable care relationships and models to improve quality of care and health outcomes while reducing total cost of care? What changes are needed to maximize how these models can achieve these objectives? First, I'll turn to Rob.
Thanks, Paul, and I appreciate the opportunity to be here today. As Paul mentioned, I'm Rob Saunders with the Margolis Center for Health Policy at Duke, and we do a fair bit of research looking at the effect of various payment and delivery reforms. You know, there's a couple of places here where we've been focused on and opportunities to improve total cost of care models. You know, there's clearly been some movement over the last several years since we've expanded the number of population-based or total cost of care models, and we're starting to see positive results in various cases, although I think the evidence is not quite where we hope it will be yet. But, you know, one of the big challenges that we're seeing is really where do you engage specialists in a number of these APMs. And, you know, a lot of the total cost of care models to date have really focused on primary care, which is incredibly important, but there's been less focus on the specialty physicians or specialized care, which is at least, you know, 90, 92, maybe a little bit more % of total healthcare spending and total healthcare in general. And so one of the challenges is what we can do to better engage specialists in these types of arrangements. You know, in our research, we're seeing a variety of strategies take place. There's some network or referral strategies that individuals, say ACOs or total cost of care organizations are using. There's some specialized types of total cost of care arrangements, like say your ESCOs for end-stage renal disease. There's some contracting strategies, maybe virtual bundles, and then of course we all want to end up in a care redesign place as well. So those are some places where I think we're seeing some movement. There's not a total silver bullet here yet, but I think there's a lot of opportunity to integrate the specialist perspective a bit more in these types of total cost of care arrangements.
Thanks, Rob. Next, I'll turn to Gary Puckrein.
So the National Minority Quality Forum, we start from the place that the healthcare system should be about mitigating patient risk. The real purpose of healthcare is to reduce hospitalizations, emergency room visits, disability, mortality for each patient. We see no Medicare beneficiary who is coming into the healthcare system with any expectation that the system is going to elevate their risk. When we look at these models are not patient-centric. They're financial models. They're just based on moving money around. And there's really no evidence, actually, that over the long course of all of these patient models, financial models, that we've seen improvement in health outcomes for beneficiaries. And, the operating assumption is that if you pay physicians this way or that way, you're necessarily going to get good outcomes for patients. I think the place really to begin is with patient outcomes, to model the system and have the system focus on improving patient outcomes. Certainly when you're dealing with equity, you've got to be able to focus down on what's good for patients and have the system organized around that. I think if the system becomes focused on patient outcomes, that we'll get the results that we're looking for. I don't see any evidence that any of these patient models in the short run or the long run are going to bring the kind of quality that certainly patients expect to get in the Medicare program.
Thank you. Next, we'll turn to Lee McGrath.
Sure. Thanks so much, Paul. I'm not sure I'm esteemed, but I appreciate the compliment, or at least starting out with that. So I'm going to take a different type of approach, although, Gary, I can't begin to tell you how much I love the sentence that the models are just about moving money around, because that actually breaks my heart, and I think you're right. I think what we need to be successful, because I actually really love CMS's mandate around we want every Medicare beneficiary to have a tight relationship with primary care. I think what we need to be able to do in order to make that work in a way that actually focuses on patient outcomes and not just moving the money around is access, investment in infrastructure in order to effectively move information back and forth from wherever it sits, whether, lab outcomes or lab results sit in LabCorp, or whether there's claim information sitting on Premera's claim system, or whether there's information from an emergency room when grandma took their kids to Florida for Disneyland. Wherever it sits, getting it in a really usable, manageable position for the primary care physician to then activate on that takes an amazing amount of investment and a different way to think about how to impact care in a meaningful way. So that care becomes about everything that happens in the patient's life, and not just when I'm standing and looking at the patient saying, hey, why does your back hurt? How can I help? Then the other third piece, I think, is the definition of primary care. I'm not sure that's been really defined. Are endocrinologists primary care? Are cardiologists primary care? And how do we think about that? And then going through the things I just talked about, access, infrastructure, in terms of data analytics. Those are things that will have to be contemplated as we think about, I hope, broadening the definition of primary care to meet the patient outcomes that we all want. So that would be where I would start from.
Great, thanks so much. So, our fourth panelist has joined, Dr. Kristofer Smith, Chief Clinical Officer from Prospero Health. Chris, if you can turn your video on if you're there. And
I am here. Can you hear me?
Yes, we can. Yeah, I'm hoping you heard the first question. I was wondering if you had some thoughts around the question on accountable care relationships and changes needed to maximize these models.
Sure. So, I think there's a number of, are we talking, I just want to make sure, and I apologize for being late. WebEx is not the preferred video conferencing application for my company. Are we on question one or question two?
Question one. So what do you see as the potential for accountable care relationships and models to improve quality of care and health outcomes while reducing total cost of care? And what changes are needed to maximize how these models can achieve these objectives?
Yeah. So I did hear some of the comments. I do think that, we're 10 years into this journey on models of care, and certainly I've had the good fortune of participating in them from both the side of healthcare delivery systems as well as for-profit companies such as Prospero or NaviHealth. I think where I see us continuing to struggle as we think about these models is often around what population are we trying to improve quality and total cost of care. And this is where I think we often struggle a little bit because, as we've heard, we want to put most beneficiaries into care relationships or accountability for quality and total cost of care. I think that there are portions of the population where we should be leaning in on certain elements of quality, whether those are measured by access, whether they're some of the primary care measures that we all are held accountable to. But I think there's not as much data that we should be holding provider groups accountable for total cost of care across entire populations. My experience working in this space is that the reward and the data that would support that there are subpopulations of high cost patients that require different models of care in order for us to achieve improvements in total cost of care. And then there's a whole tail of maybe 50 to 75% of the patients where there's not actually a lot of cost to break out of the system if you're talking about utilization. And so I think we need to start really reframe the idea that we're going to delegate total cost of care for entire populations to provider entities or to for-profit groups, because I don't see that there's a whole lot of compelling data around reducing total cost of care in most of the populations. Yet there is the ability to reduce total cost of care in certain, like the frail elderly, end-stage renal patients. And so I would lean in more on those for total cost of care, and I would think more broadly about quality in the remainder of the populations that aren't high cost with a lot of low value care.
Great, thanks, Chris. And so before we move to the next question, I want to open it up to PTAC members for any follow-up questions. Larry?
I'd like to ask Gary a question specifically about specialist participation. How do you have you managed to put enough income at risk on the specialist side for them to participate fully in value-based care? And if you're not doing it through income, are you accomplishing it through management of the network and bringing a larger percentage of their workload into the value-based care arrangement?
I presume you were directing that question really at Robert, because I think he's the one.
Oh, I'm sorry. That really went to Robert. I'm sorry.
I'm happy to chat, Larry, and I know, given your experience in thinking through a number of alternate payment models really focused at specialist participation, you understand the nuances that happen here. What we're seeing out there in the field is it really varies to what extent specialists have had their compensation adjusted in terms of those total cost of care arrangements. I was on for a little bit of the last panel where Christian was talking about some of the compensation changes that they were making over at ShinMed. I think what we're seeing writ large is that there have been very few places that have changed compensation patterns, even if they're in a large healthcare system that, say, has an ACO contract or some other type of total cost of care arrangement, that actually go forth and change compensation to their specialists. If they do, it's probably in the % range. And that's in the big systems. I think if we're talking about a smaller practice, then we get into a question of what level of their book of business or their level of their practice is actually affected by that total cost of care arrangement. And most of the time, we're talking about small numbers that we've seen in the field, with some notable exceptions. I think where you've been able to get, say, a really focused arrangement for GI, for instance, and I know you're familiar with this, where you've been able to have something like an IBD medical home or the like that's really focused on one condition and really get a practice engaged. But for many of the general specialists who are seeing a number of different conditions, usually we haven't seen a huge percentage of their compensation or of their practice revenue affected by these types of total cost of care arrangements. So I think it's a mixed bag right now is the short answer.
Lee, I wonder if you might have some comments about, again, this topic of sort of engaging specialists within total cost of care. From your view, what are the opportunities, how best to think about how to engage them in these models?
I think the opportunities are actually endless, and we have to be creative in thinking about it. But I can't keep underscoring what Gary mentioned. It can't just be about moving money around. So we need to really make sure that we're talking about access and quality and infrastructure and reducing transaction costs and figuring out how we can make systems and specialists or primary care or whomever more efficient and make it easier to do their jobs and remove the burden that has been put on them. So we can keep talking about the money, but it makes me sad if we just keep talking about the money. It should really be about something more than that. And by the way, I get that increasing access and infrastructure costs a bunch of money, but that's actually where I think our investment should lie, as opposed to just continuing to just create contracts that measure something against something and then we pay for it, because I think we haven't seen all of we've been in the value-based care world now for a while, and we need to see greater change. I think our customers, members, patients, however the word we want to use, expect a lot more from us.
Great, thank you. Josh.
Lee, thanks for those comments. And I wonder, kind of thinking about that and some of the other things that Gary and Rob have mentioned, if we kind of pull on that thread of investment and that, it takes something to then do something like and increase access and other things we care about, bring it back to the question, do we think those are things that we might change or adjust in total cost of care models? Or in your view, is that something that should be outside of that? I think that's relevant to us as a committee. The point's well taken, and for me at least, it's how would we incorporate that into specific changes in these models, or should it be separate?
I don't know if it should be separate or not. There's not a conversation that I have with a provider today as the person who's in charge of the provider network here in Washington and Alaska that doesn't involve how can I help with access? How can I help, reduce transaction costs? How can I help staff your facilities, right? Since there's a labor shortage. But so I'm not sure, whether it's separate or not, but I will just say, for example, Premera, we are literally standing up primary care. There's not enough access in Spokane. And it's a fantastic community. We love Spokane. We can't let there not be enough access. And so we just, it was exhausting, but inexpensive, but we stood up primary care, right? And we did that because we love our communities. And we're standing up primary care now throughout the state. And again, we're doing that because, we love them. How can we not just be yelling at other providers like, what do you do? Let's jointly figure out how to do this, and we put our money where our mouth is, and we invested in primary care.
And I think just building on what Lee says and underscoring Lee's point and Gary's, that it's relatively easy to change the way we pay. It's much harder to redesign care. And our research also shows that it takes several years. Step one in many of these arrangements is you're just figuring out what are the details. Like, you're giving me a claims feed. How do I even open this file? Year two, maybe you're trying to do a thing. Year three, hopefully you're seeing a result. And that's, folks who are pretty well resourced and have a good sense of what to do. I think to your question on upfront capital, I think that's a big issue here. We had early on, say, like the ACO investment model, which included some level of upfront capital. Maybe a hospital system or health system may be able to tap into capital reserves. But to start an ACO, depends on which type of ACO. We're talking probably $750,000 to get the data infrastructure, to get the people, to get the care coordinators, and all of that is upfront. And then on the Medicare side, you do that, you then improve care, and then 18 months later, you get the check that is your reward. You may or may not have the cash flow to survive, especially if we're talking about a physician-led practice and still working off cash accounting and trying to work that way. I think we've seen actors in the market help fill that gap a little bit. Your ACO enablers, your Alidades, your Privias, your Agilons, who've been able to tap in and provide some of that upfront capital. But I think to Lee's point, there's still a big need here, and it's different. The upfront capital and that infrastructure investment is different than the ongoing incentive structure that we put in place. And many practices don't have the access to capital that allow them to start putting those investments down and then waiting, 2 years, 3, to see if that investment pays off. They need, help up front. So I think we'll struggle having a payment model that doesn't include something that's thinking about where does that upfront capital come from.
Yeah, Robert, if I could follow up on that, my career started out in, health systems, and that was exactly our challenge. Was we had so many different models. Each of them required, I wish it was only $500,000 to $750,000 in startup costs, right? They often required enormous both startup costs as well as subject matter expertise that we didn't have, and then we built that over time. But each new model, you almost started over with new capital requirements to meet the needs of the model. And so what you're seeing now, I think, is almost the privatization of fee-for-service innovation in the marketplace right now, with most of the interesting investments coming out of private equity and venture capital. I don't know that we want that to be that way. I think what's also not happening is you're not seeing delivery systems really transform themselves because they simply don't have the working capital. I mean, Lee, I applaud you for trying to find primary care doctors to put across an entire state, but they don't exist in many of our states, and we don't have the dollars to invest in the salaries to pull people into primary care who might have otherwise are now going into hospital medicine or emergency medicine. So the upfront costs, if we are comfortable with the privatization of Medicare fee-for-service innovation, then we can continue to put forward demonstrations that private equity companies like direct contracting can fund, or we have to figure out a different model for a much bigger upfront capital investment.
So let me return us back to the patient for half a second. So if we look at Medicare fee-for-service right now, about 24% of Medicare beneficiaries of the fee-for-service program have diabetes. They have a 60% hospitalization and ER visit, right? 60% of them are going to the hospital or going to the ER every year. If you look at the hospitalization rates and ER rates for the last 5 years, they're completely flatlined, right? The number of people who went to the hospital or the emergency room last year was almost the same number the year before. And what that says to me, that's a system that's not learning. It's not learning one doggone thing about how to take care of patients with diabetes. We could talk about cardiovascular. I mean, we could go down the list of this, right? And the point I'm making is that that's the conversation that we're not having. We're not saying to ourselves, why is our system behaving like that? What do we need to do in order to change that? And what I'm suggesting is you got to start with the numbers. You got to start with the numbers of patients, right? I understand the financial investment and I understand the cost and all that. But the purpose of healthcare is to mitigate patient risk. And all you're doing is talking about mitigating financial risk. And so we're putting patients at risk. And that is really a failed system because it ain't healthcare if that's what the system is doing.
Great. Thank you for all those comments. I'm actually going to move to question 3 for our panelists. I want to ask about addressing health-related social needs in population-based total cost of care models. So in your opinion, what are some best practices for integrating screening and referring to address social needs in total cost of care models? Gary, I'm going to start with you.
That's a very tough question because we are not succeeding clinically. And so bringing social services into this, and I'm assuming that we're talking about housing, transportation, food, and all those kinds of things, which are obviously critical to healthcare. but is the healthcare system really built to do that right now? And to add those on, is that going to really help the situation? There's got to be some integration, obviously, between social services and healthcare. But for the moment, I would pay attention to what we're doing clinically to make sure that we're operating at the top of our license clinically, and then obviously form those partnerships with social services in order to improve outcomes for patients. But I'm not sure, even though I deeply understand that social services are critical, but I'm not sure this healthcare system is prepared to take that load on right now.
Thank you. Chris, I'm going to turn to you next about your opinion on best practices for integrating screening and referring to address social needs in these models.
Sure, thank you. So I actually think that we've come a long way in terms of inclusion of screening for social determinants into many of our healthcare environments. I think that, we've also learned that a variety of different folks, when trained properly, can do it. And you can actually use, whether we call them community health workers or even medical assistants, you can use staff that are relatively affordable to collect the information. And I think that we also have seen in the marketplace the proliferation of some solutions, whether things like NowPow or Bertha, which are providing the sort of network, so to speak, and contact information for all these social services. So I think we're actually pretty far along, and Medicare with their standardization of the social determinant screening has really helped. But I'm with Gary. I think all that we've done now through building all that infrastructure and learning has created longer waiting lists in our social service agencies. And our experience is we incorporate social determinant screening for all of our populations, and we are making referrals, but the referral isn't being acted on any faster. And I appreciate the refocus on social determinants, and I appreciate how they do are determinant of patient outcomes. But as a country, we have so underinvested in those entities that are catching the referrals. I don't think we are not making the progress we hope, and I don't think we are going to, because these social service agencies don't have the capacity to take the referrals.
Great, thanks for those comments. Lee?
I agree with all of that, and not. I think I'll take the approach of what we're doing at Premera. How's that? So with the primary care that we're investing in, we actually created a team-based way to manage the patient. And manage is such an insurance word, so I hesitate to use it, but really to provide love to the patient and create a magical moment, as we refer to it, between the patient and the physician, as well as the team that is supposed to give a big giant hug to that patient. So we've employed social workers and pharmacists and case managers and behavioral health specialists, and we have invested heavily in community liaisons to understand where affordable housing might be, or food banks, and try to create that relationship to the good people in the areas that we've invested in primary care to be able to provide that loving hug to the patient once they leave the four walls of the clinic. So that's how we view making sure that our patients, our members are getting what we think they signed up for when they signed up for Premera insurance, and what they've signed up for, or what they just deserve, right? So that is, how Premera has taken that approach and invested heavily in.
Great, thank you. Appreciate that. Rob, any comments on this?
Yeah, I think, building on what others have said, that there's been a fair bit of activity on the screening side, and I think we're getting better at encouraging screening for social drivers of health. This year, for instance, there were a few measures that were put forward in the Measure Applications Partnership Review, and think we're already seeing at least one of those proposed for some of the Medicare hospital programs, and the Measure Applications Partnership, is probably going to recommend those, some for the physician programs as well. I think, as also Bill and others, the struggle is often linking the screening to the referral or the acting on the identified social need, and that tends to be where the challenge takes place. Some examples of things that we can work on or build on would be like North Carolina's Healthy Opportunities pilots, which are doing screening but also have funding, in this case Medicaid funding, to help with the actual referred service on housing, nutrition, transportation, interpersonal violence, and also set up data tools to help with the referrals, so that there's a sense of not only the referral to the community-based organization, but information feedback back to the referring clinician to say, and here is what happened, with that case. We were able to meet that need, or we also found that there were other social needs, or we've been able to work with the patient in the following ways. I think without that infrastructure to help with the connection between the screening clinician or the screener, whether that's community health worker or the like, and the community-based organization, we're going to have a little bit of a struggle, and may have some problems in actually making things happen. The other thing that I think is worth flagging here is we're starting to see a little bit of cacophony happening in the social drivers of health screening space. We've done some just informal sort of surveys, and finding that individual systems are finding 3, 4, 5 different variants of the screening tools, each of which have different ways they're asking a question, each of which have different ways that they're looking for answers, each of which are also coding the answers a little bit differently. And we may be repeating the cacophony we have with quality measures in the social drivers of health. I mean, it's a really good thing that we're seeing so much attention paid on social drivers of health. That is a good thing. But I would hate to repeat the challenges that we have, and the burnout and burden that we have with quality measures on social drivers of health, which aren't going to help with the long-term sustainability, encouraging greater connections between the healthcare system and the social care space.
Rob, if I could just follow up your comment, I just want to find a silver lining to the social determinants, because I think the one place where, as we have in our programs, gotten better at measuring social determinants in a way that can feed into our risk stratification models. I will say that the one area that we have, to Gary, to your point about managing the medical, is we're getting better at using the social determinants to help us to identify which diabetic patient, to your earlier comment, is more likely to be the one hospitalized, because from just a claim standpoint, without the social determinants, they look rather homogenous. And once we start to layer that in, we've had some good success in highlighting folks who need more help that we wouldn't have been able to do without attention to measurable, reportable social determinants.
Thank you. Appreciate all those comments. I'm going to open it now to PTAC members. Any follow-up questions before we move to the next question? Lauren?
Just a quick question. So universally across the country, there's an issue of screening and referral to nowhere. And I'm curious, for each of you, I've heard some innovative practices you're investing in your systems. What motivated you to put the investment in actually building some of those services, and what recommendations might you make as we look at total cost of care to generate more investment in actually investing in building those resources?
Can you just clarify which resources you mean you would like us to build? The actual receivers of the referrals, or the infrastructure to capture the information?
So when we think about health-related social needs, things like transportation and housing and food security, universally across the country, there's an issue with referral to nowhere. But I've heard in you describing some of your models, you're building some of those things in. You're investing in care management, social work, behavioral health, pharmacy, the community liaisons. What motivated you to do that? And then what advice would you give to others for investing in that?
I can try. Lee, do you want to go first on that, or?
No, please go ahead.
Yeah. So, I mean, we're much like Lee, we in our programs are investing in other members of the care team, whether they're social workers, community liaisons, community health workers. We're definitely trying to surround the patients with more individuals who have skills, whether it's around managing things like social isolation, depression. But where we're not investing is we're not investing in like paying for transportation on the care delivery side. And the reason we're not, in many ways, or food, we're not buying food for folks is because it's hard to build a business plan around that. And in former life, we did that, and everybody was very excited because it makes for a good press release. And then after about 2 years, someone looks at my budget and says, why are you paying for all this food? What's the ROI on that food? And it's very challenging to build a business plan around some of those services. And so that's why I'm a little bit jaundiced that you'll get the delivery side to be able to make those investments. On the payer side, I have definitely worked with forward-thinking payers, particularly in the Medicaid space, who will partner with us on studying what the return is for these investments. But I think it's very hard to see that providers will lean into that space and make those investments.
That's a really good answer. So for Premera, I mean, it was, our employer groups were like, our patients aren't getting in to seek care. Our employer groups hire us, right, to help and do that. Like a Premera ID card should get you places, right? And so we had to answer that. I think the business case. How do I say this? So the best way to solve the business plan is if our patients stay with us, if our members stay with us for a very, very long time, the business case proves out. If they only stay with us for 6 months, it doesn't. And that is that's something we have to fix. And have to really think about, because if someone holds onto a Premera ID card, for example, for 80 years, business case works great. If they stay with us for 6 months, the business case for providing food or transportation is really tough. And somehow, I literally am like, it can't be about money. It really can't. And yet, we have to, still pay our employees. So we have to figure that out. We're committed to figuring that out at Premera, truly. We invested hundreds of millions of dollars into primary care and teams to surround that primary care. And we've invested a ton in providers that are just not owned by Premera, to be super clear, in Seattle, in Washington, and Alaska. But, it's really hard.
And I would build on. Oh, sorry. I was going to say, Paula, I would build on those two comments just to say, in our surveys and talks with delivery systems and payers, I think we're hearing similar feedback across the board. I mean, one point here would be there's a lot of technical nuance here and what you can use different dollars for. And if you are using traditional Medicare dollars, there's a set of restrictions. If you're using traditional Medicaid dollars, here's your restrictions. Medicare Advantage has a little bit more flexibility in certain areas, but not others. And being able to navigate that technical nuance is incredibly important and incredibly challenging. I think the second piece here is, and Lee, I know you hit on this a little bit, is that there's different. I hate to use the word return on investment, but there's different returns depending on what services are provided. And at the end of the day, folks have to think about long-term sustainability. And, in some cases, if you are targeting, say, food to use Gary's example, to a diabetic patient who may be housing insecure and therefore have less access to, fresh foods and probably doesn't even have refrigeration, let's say, for their insulin, that you may see see, changes in care utilization within a year. Some longer term changes, Lee, as you mentioned, may take 5, 10, 15 years till you actually see changes in health outcomes and changes in utilization patterns. And just I think a lot of folks are still figuring out what are those specific care delivery services that can take place and show changes in a short amount of time. That's a big issue with North Carolina's Healthy Opportunities pilots and Medicaid, is that they're not funding every service in transportation, nutrition, housing, interpersonal violence, but have a fee schedule of here are very specific services that they are funding, with the theory being that they may see returns and changes in a short period of time. And I think the final question here, which is an existential one, is if you want to see something done the most expensive way possible, you would have the healthcare system be in charge of it. And we don't want to have, the healthcare system take over social services. We have a well-functioning, or at least a well-defined social service system. And the question may be more partnership as opposed to healthcare trying to absorb all those services and do them in-house. But there is a little bit of a tension here as we think about social services and health and screening and meeting those needs, that we don't just have the healthcare system absorb and overtake social service systems.
I would make the argument that we've come to the place where we have to start reimagining our healthcare system. It has to be fundamentally, and I've been saying this obviously, focused around patients. I think if the healthcare system is incentivized, if the incentive is around patient outcomes, so that everyone is working competitively to improve patient outcomes, I think a lot of these issues would get addressed. I think about it, cable companies, they fight over membership tooth and nail, right? And we want healthcare plans to fight over membership tooth and nail. And I think the way you get them to do that is to really focus on patient outcomes, to make the system really focus in on patients. And unless we do that, we're just talking money all the time. And you're going to find out that you can't afford to provide food and housing and all these other things. And indeed, sometimes we can't even afford to provide care, So I think we're really at that moment, particularly given the medical revolution that's around us. The science is exploding, and our healthcare financing system is not competing, it's not supporting that. And so we have to make that shift if we're going to get the full benefit of the medical revolution that's going on, because the challenge is only going to get greater because these new technologies are going to cost, and the disparities around them are going to increase. And the only way forward, I would argue, is really to center this conversation around patients and make everybody in the system think about evidence-based patient outcomes.
Great, thank you. Angelo?
Yeah, this is Angelo Sinopoli, and this question might be directed more toward Chris and Lee. And have you explored the opportunities in your communities to partner with EMS for transportation and innovative transport models that can benefit the patients there in your communities?
Yes. We have explored it. And to tell you the truth, we do a ton in Alaska with helicopters and have invested a lot in those tiny little seaplanes that make me really scared and nervous. And it makes no Alaskan scared or nervous. And we've invested a lot into being able to provide transportation in super rural, very cold, snowy places in particular.
Yeah. So we, in a number of different stops in my journey of building complex programs, we've used EMS, not as much for transportation to say like an appointment. We've used EMS mostly for our help with unscheduled visits and acute visits. So patients call, we can't get I've built mostly home-based models for complex patients. And so mostly we use EMS and paramedic staff to get out to patients' homes because we can't get to them with their usual longitudinal provider. And I will say that when we did work with this in downstate New York around some programs for the frail elderly, we were able to partner with EMS programs. We got a response time down to under 30 minutes for patients where we couldn't adjudicate the clinical complaint over the phone. And I'll tell you, when you get that response time down to 30 minutes, boy, you can really impact total cost of care, because all of a sudden everyone calls all the time looking for help because they know they'll get help in a timely manner. So that's where I think there's tremendous opportunity to innovate in partnership with our EMS colleagues, provided we can provide the right oversight and supervision.
Thank you. Jennifer?
Thank you for a very interesting discussion. There was a comment made about the business case and the cycle time to actualize the investment in care and to see that outcome. And Gary, you made some really important comments about trying to constantly focus on being patient-centered. I'm curious, have any of you heard of programs where retention of members or looking at recidivism rates from programs is considered a quality measure? And if not, would you be open to that as a measure that we endorse?
One of our key performance measures is what we call controllable discharges from our services, because we view it as a early warning sign that we're not providing something that patients want. And if the patients and families do not believe that we're providing something of value, they won't call us. If they don't call us, we can't help them when they're having a deterioration. So we use controllable discharges or unexpected discharges as a key measure of our performance. So I would be in favor of that.
Any other thoughts from panel members? If not, we can move to question 4. So in our discussions over the last 2 days, we've highlighted the trade-offs when designing total cost of care models. One of those trade-offs potentially is between maximizing beneficiary choice of providers and providing flexibility for accountable entities in managing costs they're able to control. So in thinking about that trade-off, was interested in your thoughts on how to balance that, a particular trade-off of beneficiary or patient choice and flexibility of the accountable entity to manage costs that they can control. Lee, I'm going to start with you.
Yeah, I think that question that was just previously asked about retention feeds in here, right? And Gary, actually, what are the feedback loops? I really love that word and that concept. So we get retention as an insurance carrier, right, from employer groups and from individuals who buy our insurance on the exchange. And that's our feedback loop. I love the retention idea of incentivizing providers to hold on to patients. I think that's fantastic. We also have to make sure our premiums, that's our feedback loop, is affordable premiums. And when we don't standardize, we run the risk of increasing costs and increasing premiums. And so all of those pieces are in the mix as how we think about value-based care, how we think about partnering with providers, how we think about our own provider entity, and how we think about what we deliver consistently to the employer groups and to the individuals who buy our insurance on the exchange. I think it's important to understand everybody's feedback loops and everybody's, Chris was mentioning his signals that he uses of success. Our signal is truly, does the employer stay with us? And by the way, just to super overcomplicate appreciate this. The fact that I forget what it's called. What happened during COVID? The Great Resignation or whatever. We saw an amazing change in. Yes, we retained the employer group, but the employees were moving so fast. And therefore rating for premium becomes more complicated. Therefore, retention rates at the employee level become more complicated just because people were quitting or resigning or moving. And so all of those feedback loops are things that we spend a lot of time at an insurance carrier thinking about. And one of my favorite things that I think has happened in value-based care in the last 10, 15 years is each side has learned about each other in a different way. And so hopefully I'm providing that perspective of how we think about things so that when an insurance carrier and a provider sit down to duke it out over what makes sense, everybody understands what the feedback loops that each side is using in order to be successful within their own organization, then ultimately to the patients, members, and community.
Great, thanks, Lee. Rob, I'm going to turn to you next with this question of, Medicare fee-for-service, you can choose any provider, but when you're in these accountable entities, what's the trade-off in terms of maximizing that choice versus flexibility for the accountable entity to manage costs?
Thanks, Paul. And you're right that the trade-off here differs depending on the type of insurance. Medicare fee-for-service, where we've got full choice, is different than a Medicare Advantage, which may have some level of or likely has some level of a network, and then commercial insurance, which would have a much tighter network. I think we've seen a few different strategies done out there in the field. If we're thinking about ACOs, they may be looking at referral strategies where they're starting to look at who are the specialists nearby who are providing that high-value care, and how do we get that information into the hands of the referring clinician as well as into the patient to talk those things through at the time of referral. And that effect alone can have, or that type of action alone can have a decent sized effect in changing where folks are going. There are always countervailing forces. If someone is trying to come up with a SNF network, let's say, and only encouraging folks to be half an hour away, and folks want to stay local because that's where their kids are, or that's where their caregivers are, we're going to see pushback. But being able to provide some level of just nudges and suggestions and support at the individual clinician level, and as Gary's reminding us, to help patients as well as they're thinking about their choices, can be useful. I'd say one thing we saw during COVID, which was interesting and we didn't expect, was the number of partnership strategies that were pretty effective here. So for instance, we saw a number of ACOs working, let's say, with local SNFs on infection control or testing or treatment paradigms, which didn't even necessarily have financial relationships. It was just a straight care delivery partnership. And that those could be pretty effective in both improving care, but also in managing patients in different settings. And so I think there's some opportunity here, even if we're not talking about changing the way that we're structuring the total cost of care arrangement, but providing better focus on those partnerships or referrals to make a difference in how care is delivered.
I would just say that I think about this as competition. And we need to have competition in the healthcare system. Too much of it now is centered around, I'm sorry, CMS, but you're taking attention away from the beneficiary and not forcing the competition to be around the beneficiary so that the beneficiary is making the decision about where they're getting their health care, who's delivering it. Competition is good here. It's a good thing. And it'll force everyone to operate at the top of their license, but you're not allowing that to happen. You're interfering too much in the marketplace, to be blunt about it. And so my strongest recommendation is to get some competition into the system, to figure that one out, because I think everyone will operate in the patient's top interest once they're competing for their attention.
Thanks for those comments. Chris, I don't know do you have any particular comments around this trade-off of sort of beneficiary choice or, needing or narrow networks versus full networks versus flexibility for the accountable entities to manage costs?
Yeah, I mean, I agree with many of the comments. I think the only thing that I would add is as we think about different models that are coming out of Medicare and CMMI, anchoring on allowing patients to choose to move out of a demonstration or out of a practice, I think obviously has to be maintained. But the algorithms by which you attribute patients to practices and to programs needs to err on the side of stability in the population, because as Lee was saying, if you have 20 to 30% churn in your population, the likelihood that that's going to dampen your ability to improve quality and total cost of care, I think, is pretty well established in the literature and in our lived experience. So I would say that is something that has to be top of mind as we're developing new models of care.
Thank you. I'm going to open it up to PTAC committee members. Any questions? If not, I'm going to turn to question 5. We spent a lot of time as a committee thinking about specialty care within total cost of care models. And, there's a lot of conversation. I think we've talked about this a little bit about whether there's the benefits of having sort of a structure regarding the accountable entities. So indeed, should there be sort of specialty models that are sort of clear for the specialists to then engage in the total cost of care model versus having flexibility for the accountable entity to sort of organically determine how to incentivize providers. And Gary, I'm sorry to be talking about money, but it's part of what we're trying to think about when we think about, we're not ignoring quality and outcomes, but would be interested in thoughts around this. Chris, maybe I'll start with you on this as you think about the role of the specialists to engage them or incentivize them, the trade-offs between providing sort of a structured model for them to participate in versus having them in a total cost of care model, and then the accountable entity sort of more organically incentivizes the specialists.
Sure. Well, so just, in terms of my bias, I'm an internist. And so I believe that the data supports that we want patients to have medical homes. And I think that a lot of the work that your group is doing, that we've been doing over the last 10 years, part of what it should be trying to do is reinvigorate primary care such that 10 years from now we can see that these investments led to a larger primary care workforce, for example. And so I'm not a big fan of having sort of subspecialty ACOs. I would think that we would want ACOs that are built around primary care networks, and that those primary care networks be allowed to determine how they want to contract and what the relationship they want to be with, whether it's the subspecialty providers, whether it's the subacute rehab facilities, even the hospitals. And I think in my lived experience, as some of these models have delegated the ability to negotiate financial terms with let's say laggards, all of a sudden these entities who are trying to stay out of total cost of care models like hospitals are all of a sudden now trying to fix readmissions because they see that the ambulatory network around them is demanding that, and that the ambulatory network, unlike the insurance company, they can actually move patients. And so they can work to move a patient to one hospital 2 miles down the street compared to the other hospital who's not willing to work on these value-based incentive models.
Great, thanks. Gary, thoughts on this?
I actually like the idea of leaving the power with the ACOs. Obviously, for me, they're focused on patient outcomes, and I think of them as finding partners to help them get the best possible outcome for the patients. I think if we're forcing everyone into various systems, you're going to lose that attention on the patient. At the end of the day, the buck has got to stop somewhere, and so I would leave it with the ACOs. But obviously, they've got to report out outcomes. We've got to have that sense that they're making improvements for patients.
Thank you. Lee, any thoughts on this?
I'm not sure I mean, I'd be actually really curious what the underlining piece of the conversation or the question is. Is it we should be pushing more money to specialists?
No, it's more about do we need to create specialty models that need to be either nested, carved, sort of nested within a total cost of care, or do you allow the total cost of care entity to sort of work with the specialists and sort of organically develop what the incentives should be?
So right now we incentivize primary care. So you're thinking the insurance carriers should take the money from the primary care and move it to the specialist? Is that what the question? It's
really more about how collaboration between primary care, and it's really not so much, I don't want to overemphasize the money piece. It's more about, the reality is currently the specialists have not, even within Medicare ACOs, the specialists have not been particularly engaged within those models. And there's a lot of conversation that CMMI has had around, they have quite a few specialty models currently in the BPCIA program, et cetera. And the question is, do they need to continue some of those models? Is that helpful, or is it better to sort of focus on the larger total cost of care model?
I think the three fundamental things that are wrong with healthcare that we all need to address is affordability, access, and fragmentation of care. And I don't know if creating more models and more ways to move money around will address affordability, access, and fragmentation of care. And I'd rather talk about what can address affordability, access, and fragmentation of care. So, fragmentation of care and affordability and access, I think, can be addressed a lot by investing in sharing information and data. And I think the payer role in sharing data is gigantuum. I think the responsibility for CMS to share additional information is gigantuum. And I think the ask for physicians, even if they're not within the same system, is sharing information. So Gary's point about increasing competition, well, they also need to share information back and forth, because if the competitors aren't sharing information, you have access, affordability, and fragmentation of care problems. And so I think those are the things that need to be discussed. And that's where I would head in terms of the conversation.
Great, thanks, Lee.
Lee, can I just follow that? Can I follow that up for one quick second?
Sure. Go for it, Chris.
You said something, Paul. You used the word nesting, and I'm curious as to the other panelists. Nesting is a disaster, and it's a disaster because it introduces such uncertainty. And again, we're getting to money, but in terms of planning, if you are a provider and you want to take population risk, but you may have X, Y, and Z carved out, but you won't know until 18 months after you've entered, you create such uncertainty around the modeling and the patient attribution that if I'm a provider who is on a 1% profit margin, I have no interest in figuring out whether that complexity is going to hurt me or help me.
I just want to pick up on something Lee said about data. CMMI could play a very big role in freeing up data because we're not going to get great healthcare until the data is moving around. And so if I was sitting there at CMI and I was really thinking about innovating, I would be figuring out how to break down these data walls so that we can share information across the system. And I think it would do dramatic change of the kind of care that patients are receiving.
Thank you, Gary. Rob, I know you've done a lot of thinking around this. I know you alluded to some of this in your opening question remarks. Any other additional thoughts around this?
Yeah, and just a few thoughts building on what Chris, Gary, and Lee have said already. I mean, I think three thoughts here. One, if we look at and talk to specialists now, they don't really feel like a lot of these total cost of care models are for them. That can be just a total lack of awareness. If you ask folks who are in an organization that is an ACO, did you know that you're part of an ACO? And senior clinicians, senior attendings, down to trainees will look at confusion at you if they even know what that word means, let alone feeling like that represents them and their care. So, I mean, I think there is clearly a need for more focused on engaging specialists. It's hard to see that there will be one solution given the different types of specialists and subspecialists we have in play right now. In some cases, it may make a lot of sense to pick a particular population and have a model that is very focused for them. ESRD, younger inflammatory bowel disease come to mind, where you've got a condition that is managed by a specialist, and that specialist is in charge of most of that person's care and would be expected to manage that. In other cases, you could see more of a case of having a total cost of care arrangement and then thinking about where there's opportunities to pull folks in. I think the third point here is really the technical, and Chris noted this, that some of the challenges we've had to date in nesting, say, bundles within ACOs have been challenging from a technical perspective, the challenge from an implementation perspective. The ACOs would note that they are taking a lot of the risk here of, if the bundle's doing well, then they don't really see any advantages to that. And so it makes it difficult to plan. It makes it difficult for them to succeed in their role. And so where there may be opportunities to, say, move that nesting approach or that sort of coordination approach to, say, like CMMI or to whoever the payer is in this case, so that they're bearing, say, some of that actuarial risk as opposed to that ACO having to think about, all right, if I'm participating in this type of ortho bundle, I'm going to be, harmed if that goes well because I don't get to see that type of return. So the short story here is I think we've got to do something here more on specialty payment reform to make sure the specialists feel involved. There'll probably be some diversity, and the technical pieces are non-trivial, and we're probably going to need to see a lot more improvement there.
Great. So I'm going to just move to the final question for our panelists, and appreciate all the discussion. So for each of you, just interested in hearing any final thoughts or insights you'd like to share as PTAC thinks further about population-based total cost of care models. Gary, I'm going to start with you.
I think we're at a great moment here where we can do a lot for the future of healthcare. I don't think the value assessment models have proven themselves. Actually, we've been doing it since 2005, by my recollection, and they haven't really worked. And so I think the moment has come now for reimagining, and I think that imagining has to be around the patient. And I think CMMI has a great opportunity here to break down all kinds of walls and help put together a healthcare system that has to now take care of a diverse population. We haven't even gotten into the issue of diversity and inequities and all that. And all of that has to be addressed. And I don't think that the current system is really designed to take on those kinds of challenges.
Thank you. Chris?
Thanks. My final thoughts are just going back to my initial thoughts, which is I think there's a lot more evidence around certain large populations of patients who need alternate models of care, and that many of the people who are insured through Medicare or Medicaid who are relatively healthy do reasonably well in the current system. And so I would continue to ask that you consider, if total cost of care is the top priority versus quality, then you have to find populations where total cost of care total cost of care reductions can be achieved because we believe that there is low value care being delivered to those cohorts. There is not compelling evidence that for much of the cohorts that we're trying to delegate at a population level, that there's a whole lot of total cost to strip out of their medical expense. Thank you.
Thank you. Rob?
Yeah, and I think I have three thoughts. Echoing Gary, I wish we would have talked a little bit more about health equity. There's a lot, and we've been writing a lot about this recently. There's a lot of opportunity to leverage these types of total cost of care and accountable care arrangements to improve health equity, but they have to be thoughtfully designed, and they're also, it needs to be thoughtfully implemented. So I think that is one place where we could push a bit more. Related but different, there's also a tension here in how we've been engaging the safety net in these types of total cost of care arrangements. They've largely been left out for a wide variety of technical reasons. But if we would like these types of total cost of care arrangements to reach a large portion of the U.S. population, especially those who are living in more traditionally vulnerable areas, involving the safety net is incredibly important. And finally, just to go back on the primary care specialist collaboration point, that there's a lot of potential here, and I think this particular moment, there's a lot of questions technically about how that can be done in a total cost of care arrangement. But anything we can do at this particular moment to help with that type of collaboration, we welcome.
Great, thank you. Lee?
Since we have 30 seconds, because I actually have a hard stop at 9, I guess I'll just leave folks with something that I tell my team all the time. We got to lead without fear, and only the bold survive. And I think it's our time to really answer what every single person in America is screaming and yelling at us about. And we need to listen, and we need to lead without fear, and we need to be super bold here.
Great way to end. Thank you, Lee. So on behalf of the committee and our audience, I would like to thank each of our panelists for their insights today. We're grateful that you have been generous in sharing your expertise. So at this time, we have a break until 12:45 Eastern Time. Please join us then. We will begin with our public comment period, followed by our final committee discussion to wrap up the meeting.
Produced by the U.S. Department of Health and Human Services.